CSF. Thank you all for attending and listening. I'd like to present research findings from a study conducted in Kisumu, Kenya. We wanted to provide some background information, as many people all know, that sub-Saharan Africa bears the burden of HIV infection worldwide, with prevalence of estimated at 67% of all cases. Particularly in Nyanza province of Kenya, the prevalence is approaching 15%, and this is where we decided to focus our research efforts. The nature of the problem with regards to safer methods of conception for HIV seropositive couples is that approximately 20 to 50% of HIV-infected individuals desire children, and childbearing desires may lead to unprotected sexual intercourse and/or non-disclosure of HIV status. Particularly amongst those that are HIV seropositive, when pregnancy does occur, there's an increased risk of HIV transmission to the uninfected partner, approximately almost 2 times the increased risk of acquisition. So this brings us to the point of our discussion where there's a need for safer methods of conception, particularly to help curb the HIV incidence, guide HIV prevention interventions, and help HIV-infected couples fulfill their reproductive goals while minimizing the risk of HIV transmission in the partnership. And particularly, this can be considered a harm reduction intervention. There are some ethical implications that must be addressed and considered when talking about safer methods of conception for displaced couples. All couples and individuals have the basic reproductive right to decide freely and responsibly the number, spacing, and timing of their children, and to have the information it needs to do so. This is the definition of reproductive health as defined by the World Health Organization. And according to the Kenyan Constitution of 2010, all individuals should have the ability to obtain the highest standard of health, which includes the right to health care services, including reproductive health care. Assisting HIV-infected people in their basic human right to conceive is something that we should be concerned with. And healthcare providers are responsible for providing resources to help couples safely conceive, again, to minimize the risk of sexual inferiority and HIV transmission. The safer methods of conception that are available for HIV seropositive couples include, but are not limited to these about to mention. One, timed unprotected intercourse where the menstrual cycle is followed and couples are counseled on the fertile period and when to engage in sexual activity. Others include use of pre-exposure prophylaxis coupled with other interventions, as well as early initiation of therapy for the HIV-infected person, and also vaginal insemination that can be used by couples, particularly those where the female is HIV positive and the male is HIV negative. And then sperm washing is another intervention coupled with other assisted reproductive services that can be used as safer methods of conception for supporting couples. The objective of our study was to assess the availability of preconception counseling as well as reproductive health services for HIV-supporting couples. We conducted 4 semi-structured focus group discussions that were mixed gender and single gender, where we had HIV-supporting couples present either with their partner or alone as all males and all female groups. We had a total of 13 women, 12 of which were HIV positive, 1 was HIV negative, and 12 men, where 11 were HIV negative and 1 was HIV positive. We used a grounded theory approach to conduct our analysis of the trans-track focus group discussions. For our cohort, the mean age amongst women was 27 years and for men 36 years. The number of children in the partnership averaged to be about 2 children per couple, and the years in relationship prior to HIV diagnosis was 6 years. So our findings were that all couples desire children, and the ideal number of children was anywhere from 2 to 4. And factors that were associated with desiring children included societal pressures from family as well as cultural, and the fact that they had 1 child, or that the couple had experienced the loss of a child, and in couples where they only had female children, the desire for more children was higher. Overall, with regards to reproductive health services, HIV-infected women expressed that they were unaware of safer methods of conception. We found that couples were interested interested in safer methods of conception, and the challenges that they encountered discussing their childbearing desires with their healthcare providers were primarily twofold. When it came to healthcare provider-specific challenges, they noted that there were discouraging attitudes that they encountered from their healthcare providers. Also, they felt as though they could not relate with their healthcare providers because the majority of them were younger age than they were, and they didn't feel like they could relate with them on that level. And then also, couples, particularly HIV-infected women, expressed that they were told that they would experience worsening of their health status if they did try to conceive. All the couples reported that there were a lot of time constraints during the visits, and providers did as well in another setting, described that there was just so many pressures to get through all the clientele in the clinic in such a short period of time that we didn't have time to discuss safer methods of conception. So recommendations from our study was that we needed to create a standardized preconception counseling method for HIV service-supported couples. We needed to also identify and target HIV service-supported couples for services, and also to train healthcare providers on conducting preconception counseling. This is ultimately the goal that I think is healthcare providers providing care to HIV-affected couples need to attain. When we, on the individual level, when we identify individuals that are HIV positive, they will receive HIV counseling and treatment. In addition to that, we should consider providing them services around family planning as well as education on safer methods of conception. In reality, a lot of these services end up being provided in a vacuum or separately. And I think we need to move towards integrating these services into HIV treatment in order to provide comprehensive and productive services. Ultimately, on the community level, we'll be able to increase community awareness about HIV and also prevent decrease the prevalence of HIV infection in the local community, and hopefully increase uptake of contraceptive methods for those that do not want to have children in the immediate time period, and for those that do want to conceive, that we need to be able to provide them with information to safely do so, to decrease the risk of HIV transmission in their partnerships. As providers, I think we need to look at this statement here and as a model of what we should try to attain in healthcare. This is a statement from an HIV-affected female activist. Yes, you can have children, and it can be done totally safely. People living with HIV can conceive without passing HIV to their partners and have healthy babies. Everybody here in the clinic will support you in this process. We are here for you. Finally, I'd like to close with a statement by Mungo that was presented at AIDS 2012 a few months ago. We have a real opportunity in the history of this disease to make a remarkable difference and save lives. This is not a choice, this is an obligation, and we shall be judged on how to use this knowledge that we have to save lives, to save men and women from getting infected with HIV, and hopefully fulfill the dreams for future generations of an HIV-free life. I'd like to acknowledge Dr. Betty Njoroge, Dr. Elizabeth Bukusi, Craig Cohen, my co-investigators on this study, as well as staff, administrative and clinical staff at the Faces in the Healthcare Clinic and the clinic clientele that receive their care, and our funders as well, CFAR, for supporting this project. Thank you.
Thank you so much for keeping time. Just a second. Not 10 minutes, 7 minutes. And that is 3 minutes. So please keep your questions until the end for discussions. Write them down somewhere until we hear from all the presenters. If you find the presenters, you have 10 minutes. If you can take less, the better for us. So the next speaker is none other than Megan Huchko. I hope I've gotten the name right. She's an assistant professor at the University of San Francisco. Working with Festus Cambridge in Kisumu for the past 4 years, so the central Kenya. She's going to speak to us about integration of cervical cancer, screening and prevention in HIV-care at Festus Clinic in Kisumu. I think this is a very good discussion considering the association of cervical cancer and HIV. Welcome.
Thank you, and thank you for that introduction. An introduction to the topic, which Dr. co-wrote this morning, called The Missed Opportunity in HIV Penetration. So why is cervical cancer important when we think about reproductive health and HIV services? HIV-infected women have up to a 4-fold risk of HPV infection, cervical cancer, and invasive cancer. And cervical cancer and HIV both have high prevalence in developing countries, where there may be limited infrastructure for prevention and treatment services. However, over the last decade, HIV-care and prevention efforts have significantly decreased the incidence and improved the disease prognosis. There's been no concomitant improvement in cervical cancer prevention or survival. So why is that? There are inherent challenges with cervical cancer screening in low-resource settings. I think primarily there's a lack of political will and funding for cervical cancer screening because parent prevention of chronic illnesses have often been given lower priority given extreme mortalities in these areas. Cervical cancer is considered both a chronic illness and an area of reproductive health. Instead of receiving support and funding from both of those areas, it's often orphaned and considered part of either of those areas, as we can see with limited attention to cervical cancer and reproductive health integration so far in this conference. I think also importantly, the successful cervical cancer prevention programs that are used in resource-rich settings that have dramatically decreased the burden of disease, and I'm talking about CAP screening and cytology, are just not practical in those resource-limited settings. They require healthcare infrastructure for specimen transport and follow-up, clinic supplies and staffing, laboratory equipment, supplies, and trained cytologists or pathologists to interpret the pathogens, tracking strategies for the specimens and the patients, follow-up visits, because women get a pap smear on Monday and come back for diagnostic step or treatment decisions. And then there are the always present limitations of space, water, and electricity. But there can be strategies for cervical cancer prevention in low-resource settings that address these challenges. First, appropriate screening techniques need to be chosen, and viable options are visual screening methods such as visual inspection of acetic acid, or a simple biomarker testing approach such as HPV or some more novel biomarkers that are being tested right now. Putting screening and treatment into a single visit is an approach that's been advocated by many. Providing safe and effective treatment in the clinic by the primary healthcare providers is essential. And it's really important to think about integrating cervical cancer prevention into existing healthcare infrastructure so that we don't need to think of going to a separate clinic visit or meeting with the provider or becoming familiar with the separate healthcare settings. So HIV clinics will provide a perfect setting for this because they have the trained staff, the regular follow-up that women require for HIV-care or disease monitoring of disease progression, and they really have that high-risk population of women who are, as I said before, at risk for cervical cancer. So with that in mind, I want to talk briefly about visual inspection techniques, visual inspection of acetic acid, or VIA. This is what we call the service on board, and this is prior to the application of 3 to 5% acetic acid. This is a very simple test. After applying the acetic acid, the examiner lifts a minute or two, examines the surface again, and any abnormal lesions will turn white. A negative test would be a test with no changes. The good thing about a negative test is that there's a 99% negative predictive value, meaning that women are very, very unlikely to have disease that's not picked up. So visual inspection of acetic acid is a simple, inexpensive test with very similar specificity and sensitivity to pap smears, and it can be done in a single visit. So when we go to get their test, we get their results at the same time. So with that back in mind, I want to talk about our project in cervical cancer screening and prevention at BASIS. We heard about the BASIS clinics this morning. We introduced cervical cancer screening and prevention, or CCSP-care, in October of 2007. We based our protocol on WHO and International Agency for Research on Cancer guidelines for screening and prevention in resource-limited settings. There are 3 main components of our program. First is clinic and community awareness building. Second is the education and training of staff, both clinical and non-clinical staff at BASIS. And third is the provision of services, which include offering screening with VIA, all non-pregnant women over 23 years old, followed with a diagnostic colposcopy and biopsy if necessary, and then treatment is provided in the clinic with loop electrosurgical excision procedure or LEAP for all women with CIN-2, which is the cervical cancer procedure. This is a schematic of our protocol. I don't want to get lots of details, but the important key components are that women are screened every 3 years if they have a negative test, and at this point in time, we confirm all of our positive PIAs with colposcopy. In the future, we'll be phasing out that colposcopy and biopsy step and moving straight to a see and treat protocol where women get treated based on a positive PIA. So this isn't just screening that takes place inside of a clinic. We've tried to make this a fully integrated screening program. So this has happened through several steps. I think the most important was that we created a CCSP team integrating members from all departments in the clinic, from reception to data to lab to administration, and of course the clinical benches. Attention to screening and education to take part at all types of client visits, starting in enrollment. We have an educational module about CCSP. That's part of the HIV education talks that all people get when they enroll in care. At routine clinic visits, eligible women can be identified at the triage desk, the reception desk, and in the clinical rooms. Counseling can be done by the clinic and community health assistants or CHARs, nurses, and clinical officers. And then we really tried to make sure that all clinical officers are trained in PIA. And then follow-up for cervical cancer is nested within the routine HIV-care visits. So any treatment or follow-up exams that are needed are taken care of as a woman would come back to the regular HIV-care. Home visits for women that would need more acute care or a loss of follow-up are nested within the routine home visits that are done as part of cases care. So we failed to present our outcomes for the first 4.5 years of the program. We screened 6,740 women. We diagnosed 474 cases of CIN-2, giving us about an 8.5% prevalence. We performed almost 500 leads with no moderate or severe adverse events. We've analyzed our recurrence rates at 1 year with about a 10% recurrence of disease and about a 19% recurrence at 2 years. We've diagnosed 58 cases of invasive cancer, and I think this is important because 54 of them are diagnosed at stage 1A1, where we have treatment at a local hospital and potentially even have fertility-sparing treatment, but certainly quite prolonged treatment. We've also looked at clinician outcomes, in terms of training and staff satisfaction. So far, 70 clinical officers and nurses have been trained in the screening techniques. 12 clinical officers have been trained in LEAP. 35 CHAWs have been trained in cervical cancer screening education. And we recently had our data manager go for an intensive monitoring and evaluation training with AMRA. We did a qualitative survey of staff satisfaction after we piloted the CCSP program. At that point, 100% of the clinical officers trained reported increased knowledge of and comfort with health exams, and 90% reported enjoying the mentorship process and felt the skills would be valuable to their career. We've certainly learned a lot of lessons through our successes and challenges over the past 4.5 years. I think, importantly, we feel like CCSP is an example of a successful cervical cancer screening and prevention program in an HIV-care setting. And a key part of that is really nesting the initial and follow-up visits within the routine clinic visits. The team approach, which included all departments, was a key factor in success, as well as our community awareness and patient education campaign to really get buy-in and generate enthusiasm for screening. Importantly, sustainability of the program depends on all clinical staff being trained. That's been one of our challenges as staff has rotated in and out, and we've had an increasing proportion of administrative health staff join the business program. And we learned from trial and error that data collection and tracking systems should be designed at the start of the project to be able to monitor and evaluate the program in real time. So the next steps, we recently launched a scale-up of these services to other BASIS-supported districts in partnership with the Ministry of Health, and we've gone to a single-visit see and treat model, coupling visual inspection with C acid with treatment at the same visit. There are the process to determine the efficiency and cost effective of more streamlined programs, and I'll present some of the cost effectiveness data tomorrow. We really need to design large-scale, rigorous trials to determine the optimal mode of integration, analogous to family planning trial we heard about this morning. And I think we need to start thinking about how the lessons that we've learned from the HIV C6 integration can be spread to general outpatient settings to improve access to these important services to all women across HIV status. Thank you very much. I'd like to thank the co-authors listed and the authors.
Thank you so much, Megan. I'm sure there are questions about the presentation. Please, again, put them down until the time for discussion. The next speaker that I would like to introduce is going to speak about setting up evidence-based integration model in Tanzania, lessons for implementing partners, policymakers, and donors. This is Tricia Petruney, who is a senior technical officer in the research utilization unit at 360, FHI 360 in North Carolina, USA. Welcome.
Thank you very much. And thank you to all of you for being with us today and battling, I think, the post-lunch slump. And all of us are trying to do our best to keep you awake, so thank you. I'm really actually delighted to have this opportunity to present to you a little bit about FHI 360's experience with contributing to a scale-up process for an evidence-based family planning and HIV integrated model in Tanzania. And what I'd really like to do today is to not only share with you what the evidence base said around a particular research effort, but to really tell you more about the story of, in this case, sort of what happened next. And I'm giving you fair warning that it includes the good, the bad, and the ugly. The story started about 6 years ago in 2006 when FHI 360 conducted a needs assessment to find out what levels of unmet need for family planning existed among women attending HIV-care and treatment sites in Tanzania. I think not surprisingly to this audience, that needs assessment revealed high levels of unmet family planning need among sexually active female clients at the HIV care and treatment sites. Like it does for all women, access to family planning helps prevent unintended pregnancies, but also for women living with HIV who do not wish to have a child. It also helps reduce infant HIV infections. Furthermore, Tanzania right now currently has national level goals to increase the contraceptive prevalence rate across the nation by 2015, and it has a goal to reach 80% of all PMTCT clients with messages about family planning by 2013. So with the needs assessment, alongside these national goals, it became clear to the Ministry of Health and to us that it could be a potentially valuable strategy to introduce family planning services into the HIV care and treatment settings. So in 2008, the ministry requested that we assist them in developing and testing a facilitated referral model for introducing family planning to the HIV care and treatment centers. And by facilitated, what we mean is an enhanced referral protocol that encourages the providers to actually physically accompany a client from one service to another. In 2009 and 2010, with support from both the TIDES Foundation and USAID, we designed and tested a model for facilitated referrals in 12 facilities in 2 regions of Tanzania. In that model, when clients came to the C2C, the HIV Care and Treatment Center, they were screened for their fertility intentions. And based on that screening, if they were in need of family planning, then they were referred and accompanied to the family planning clinic for full informed choice counseling and method provision. The study revealed that post-intervention there was a decrease in unmet need from baseline to post-intervention, that modern non-condom method use more than doubled, that dual method use increased, and also I think interestingly that clients reported that that they would have preferred to receive their family planning method at the HIV care and treatment site instead of the family planning clinic. So shortly after the study was concluded, we disseminated the results to the ministry and other implementing partners in Tanzania who work on both reproductive health and HIV. Now, based on our study findings and also with the knowledge of a similar effort that was conducted in Tanzania around the same time by Colombia's ICAP program, at that dissemination meeting, the Ministry of Health mandated the scale-up of integrated services across the country. In addition, they asked that the model be expanded to include provision of short-acting methods up through implants at the HIV sites with referrals to the family planning clinics only for longer-acting methods. So I think here's the point in the story where many of you have probably also found yourselves. You have successful results from pilot intervention, you have good buy-in from the local government, but what comes next? I think taking a successful intervention from pilot to scale is no easy task. There's a lot of puzzle pieces that need to fit together. So in this case, the ministry appointed us to help lead a task force with ICAP and with the Elizabeth Laser Pediatric AIDS Foundation to help address issues such as commodity procurement and security, training, supervision, and all of the infrastructure and logistics that go with the model. So you can just see here a couple examples of the core activities that moved the integration effort forward. We completely revised the national training curriculum package for HIV care and treatment providers to include family planning training. We then trained national master trainers on the package so they could deliver it to HIV providers throughout the country. We oriented and engaged local government health teams. And importantly, we revised the national HIV care and treatment record form to include codes for family planning so they could actually report on the new services being delivered at those sites. So here's where things stand today, at least with regard to geographic scale-up. So back in 2008, when FHI and ICAP were rolling out pilots, it was in 3 regions and 18 facilities. But as of 2012, it has been scaled up to 116 facilities spread across 13 regions, being implemented by 4 different organizations. So here's just a little recap of the main points of the story. After an initial needs assessment, a pilot was designed. It was found to be effective. After that, the ministry made the decision to adapt and scale up the model, and with partners, the process is continuing. But, I think there's always a but, right? It's not necessarily easy. If you think about how difficult and time and resource intensive it is to get services integrated across a couple of sites to do a pilot study, think about then what it takes to do that across the whole country and at the same time without those same resources that get dedicated to a specific research effort. So, some not insignificant challenges have persisted that I think warrant some attention. Some of them are the more usual suspects, like lack of commodities, but I think others that I just want to quickly highlight have to do more with harmonization and sustainability. And those are going to be the real challenges for any of us trying to roll out and scale up something that's integrated across the 2 traditionally parallel sectors. So even with successful study results and proactive support from the government in a country like Tanzania that relies heavily on external funding to deliver health programs, it's actually really difficult to get all of the various donors and all of the various partners on the same page with the same plan at the same time. So more simply what ends up happening is you have donor A funding NGO X for one thing, donor B funding NGO Y for another thing, and they talk. But it's not necessarily always in the most collaborative, coordinated manner. I think what actually ends up happening because of this ad hoc and decentralized scale-up process is that there are important implications on things like trainings, commodity forecasting, and I think most critically on being able to really systematically monitor what is being rolled out and then to evaluate what the impact of those new services actually are on health outcomes. So up to this point, we've learned a couple of things from our experience. 3 simple lessons. The first being, after good research results from a pilot, you can't necessarily and shouldn't necessarily scale up overnight. It takes a lot of time and coordination. Second, that partnerships are key. No one NGO or implementing partner or even one government unit should be trying to scale something up. We're talking about an integrated model of service delivery. And then the third, that is if we're meant to be successful in linking these two traditionally separate services in any country, the effort needs to be first and foremost guided by the government level decision makers, and then that plan supported by donors and partners in a harmonized, systematic way. So because of those lessons, our recommendations that I will close with are when you're trying to identify effective integrated models and take them to scale, you should begin with the end in mind. Don't fall victim to designing and evaluating things that are overly complicated or overly expensive that in a real-world setting would not necessarily be likely to be scaled up. Also, when designing and integrating integrated services, remember to give full attention to all components of the health system. I think most of you know that it's not just about training. Next, when you're taking something to scale, once you've evaluated it, remember to monitor. Keeping track of what's happening as the intervention spreads beyond the pilot is critically important, because sometimes things that worked in that controlled setting do not actually end up working in the same way when you scale up. And finally, as with any endeavor, we have to keep not only donors apprised of the value of investing in integrated systems, but also domestic governments, so that hopefully over the long term the linkages become built into national budgets, as well as services that become institutionalized and sustainable. Thank you.
Thank you, Tricia. I would like to propose us to stand up. I have noticed something. Let's all stand up, please, and stretch. Where's the condom man? Have you stretched enough? Okay, let's make a 360. You can all go to the FHI. 360, then we sit down. Okay, thank you so much. We are going to have two speakers now from Malawi making a presentation on saving lives through the first 1,000 days of integration. I didn't want to know what's magical about 1,000 days. So we hope that you'll be telling us that. And the two speakers are, the first one is Chancy Mauluka, who is a health advocate in Malawi, currently working at the Hopkins Center for Communication Programs. Then midway, I think he's going to invite his co-presenter, Patrick Omar, an environmental health officer from the Ministry of Health, Malawi. He is currently working as a district environmental officer.
Okay, thank you very much. Ladies and gentlemen, our presentation is going to be in two forms. The first one is going to be oral, as I'm speaking like this. And then the second section is we're going to have a quick video just to make sure that what we are saying here is has some vivid presentation. And as our title it says, saving lives through the first 1,000 days. It's about the days from conception to the first 2 years of life. And this is an intervention which departs from the sun. Maybe some of us already know the scaling up nutrition. But here, what we are saying that we are saving lives through the first 1,000 days. We are departing from the, we are taking a model that departs from the essential nutrition actions. So we take the essential nutrition actions and improved growth monitoring as an entry point towards other interventions like the family planning, HIV/AIDS, STIs, and more specifically PMDCT in this project, and then the gender and immunization and hygiene. So as I explained, we departed and depart from mother-father support groups wherein sensitization and counseling was conducted in terms of the essential nutrition actions, which are maternal nutrition, exclusive breastfeeding, complementary feeding, feeding of the sick child, control of iron deficiency or anemia, control of vitamin A deficiency, control of iron deficiency. And then from these activities of essential nutrition actions, we advanced still to improve the growth monitoring. And what happens is that why we call this improved growth monitoring is that at these growth monitoring sites, we established counseling corners. First, I should say that way is followed by immunization and then counseling, which the counseling is in terms of the NRs, the essential nutrition actions, HIV/AIDS and STIs, family planning, malaria, and gender. So the arrangement is that we have these counseling corners which were introduced at the growth monitoring sites, and these were demarcated in terms of the age of the child. For example, 0 to 6 months, 7 to 11 months, 12 to 24 months, and also in terms of themes, like the family planning, we have a family planning corner and the HTC corner, right at the growth monitoring sites. So counseling starts with observation of the child, and then the mothers proceed to their different corners. And then the integration, what we're talking about is that we have entry points. How would we convince the mother that we now are not going to talk about just nutrition, and then we're going to talk about HIV/AIDS? So the entry points are that, for example, in HIV/AIDS, you say that during pregnancy, breastfeeding, maternal nutrition contributes to PMTCT. And then, for example, infection prevention due to good nutrition, and then other entry points. And then we have a number of key messages and interventions in this area. For example, there is a continuous couple HTC and exclusive breastfeeding as a PMTCT method, compliance to ART regime, and we will also conduct mother-infant pair follow-up, where now we depart from these growth monitoring sites, follow the mothers in their communities, and sometimes refer them to the health facilities. And then we also have entry points. As I said, every theme has an entry point. In family planning, we see that the entry point is that poor child spacing contributes to malnutrition. For example, there is a premature breastfeeding cessation when a mother is pregnant. And then we have messages and interventions, for example, education on family planning methods and method mix, geoprotection, and etc., etc. And there is provision of different family planning methods. For example, DMP, that is labeled by training, HSAs and oral bills, and calendar method by community distribution agents. And then there is counseling and on other issues. And then another area is the STIs. The STIs comes as an extension, a departure from the entry point of HIV, where we say prevention of STIs contributes to prevention of HIV infection. And these, just to make you remember, are entry points that make us convince the caregivers that why do we now start talking about these issues just apart from the nutrition. And then the key messages and interventions are that we have dual protection, and then we encourage the resistant couples and reinforce those that are conforming. My friend is going to continue with the next slides, and then we go.
Thank you so much. That's everybody okay from Chancy. Now, on the education part, we was talking about malaria immunization and hygiene. Malaria prevention during pregnancy is a way of PMTCT, and you know hygiene is also a tool which is used for disease prevention. And also, we also incorporate immunization, which is also in the prevention, especially for children. On malaria, there are some messages which are given to caregivers, and also we distribute nets to pregnant mothers, especially during the ANC first visit. And also we distribute the distribution of hygienic kits to couples under mother, father, infant, infant pair follow-up. This is to mothers with exposed children, and also immunization to all children, especially the under ones. Integration of gender and elimination of violence against the women. Violence against women, we know that is contributed to healthy during pregnancy and breastfeeding. So, husbands are encouraged to support pregnant and lactating women to contribute to good health of the women. And also, there are some messages which are given to the caregivers, especially education and counseling on the male participation in maternal health. And also, there is a counseling on the condom use for discordant couples. The successes and challenges. Just because of this program, we managed at least to save the lives prevalence of about 92% of HIV-free children were born from exposed mothers, and also 65.9% increase in attendance in terms of improved GAP site, that's good modern promotion, and also immunization coverage has increased from 71% within 6 months. And also we managed to at least decrease the underweight, which has started from the 4,571 children to 3,454 children. Now, this is the video which I think Chancy was talking about.